Hello, welcome to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Each episode, we bring you a conversation with leaders across the healthcare industry, exploring topics ranging from new treatment techniques and interventions to novel service delivery methods and business models. And now your host, Rafi Salazar from Rehab U Practice Solutions, a leader in patient engagement and retention strategy. Let's explore the possibilities of a new healthcare.
Well, hello. Welcome to another episode of the Better Outcomes Show. I'm your host, Rafi Salazar, but you already knew that from the intro, didn't you? If you're new, welcome. Thanks for spending some time with us as we explore just different ways to approach healthcare. It might be a different business model. It might be a different delivery model. This week, we're actually going to be circling back to a foundational principle that we follow here at the Better Outcomes Show and that we use in most of the work that I do as a consultant through Rehab U Practice Solutions, which is taking a biopsychosocial approach. A couple episodes ago, we had Bronnie Thompson from New Zealand come and talk with us about chronic pain and about really high-level discussion about the biopsychosocial model, about what it is, about how we use that to approach patients in pain. And this week, we've got a couple practitioners who were involved in day-to-day practice, and we're going to talk a little bit more in depth, a little bit more in the practical, if you would, about how practitioners and clinicians can begin treating patients in chronic pain or experiencing chronic pain. So both of the guests this week are founding partners of Aspire OT, which is a continuing education company that helps occupational therapists get continuing education units for their license. But the way we connected was through a continuing education course that they were running here in my city of Augusta. They were kind of doing the tour, and I ran into them, and we kind of realized that we had a few mutual interests in the biopsychosocial model and about chronic pain management. So Kimberly Braden is an occupational therapist. She's been working in the field for about 25 years. She started her career as an assistant, then went back to school and became a licensed occupational therapist. Her administrative experience is pretty vast. She was doing marketing and admissions for a while. She was the clinic lead of an outpatient chronic pain program. She was a manager of a multidisciplinary rehabilitation clinic. She was also a regional director of operations and a corporate director of operations. She was also chosen to be the Occupational Therapy or American Occupational Therapy Association 2017 leadership development program for middle managers. So she ran through that program as well. And then her professional experience kind of, again, is we've got some good guests on the show. They have a lot of experience. They're experts in their field. So she's been an author, a contributing author, a co-author of peer-reviewed publications. She's been a mentor to new clinicians, a guest lecturer at all kinds of universities, and an instructor for continuing education workshops nationwide. And that's how we ran into each other, was through a course that she was running. And now she has the great, she calls it the great pleasure to serve as one of the founding partners of Aspire OT, which is a continuing education company that's exclusively for occupational therapy practitioners. Her partner in this, Nicole Rowe, is a CODA, or a Certified Occupational Therapy Assistant. She's got 8 years of experience as a clinician treating patients from acute care, long-term care, skilled nursing, and then a lot of her experience has been in chronic pain, chronic outpatient pain management. She's actually got a pretty interesting story or journey into becoming a clinician. She was actually in radio, in PR for a while before she decided to go back to school and become a clinician. So we talk about that in the show as well. She's been published in OT Practice. She's co-authored 2 continuing education articles. And then she was also the recipient of the American Occupational Therapy Association's Terry Britwell Partnership Award in 2018. And she and Kim both received that award. And she was also chosen for the Gary Kielhofner Emerging Leader Award in 2020. So as you can see, both of our guests this week are experienced, they're well-rounded, they've got the credentials. And we, like I said, we talk a lot about the biopsychosocial model in this conversation, but we talk about it more from a practical aspect of, okay, we understand the biopsychosocial model. We understand that we should be looking at patients in their entirety and not as just the sum of their symptoms. But how do we do that? What does that translate to, and how does it look? How does it affect the way we develop treatment plans with our patients and the way we might communicate? So without further ado, let's dive into the episode. Here is Kim and Nicole from Aspire OT talking about the biopsychosocial model specifically for the treatment of chronic pain. Hey guys, welcome to the show. How are y'all?
We're well. Excited to be here.
Alrighty, Nicole, we'll start with you. Tell us a little bit about yourself, kind of your professional background, and kind of what brought you to where you are now.
Awesome. So I am in my 8th year as an occupational therapy assistant. I am currently working one of the founding partners for Aspire OT, which we're going to talk a little bit more here in a minute. I also serve as an adjunct instructor for an OTA program in East Tennessee. For volunteer work, I serve on the Student Involvement Committee for the Tennessee Occupational Therapy Association, which I really enjoy. We're obviously trying to get students more involved and advocate and meet their needs, which I think is a lot of fun. Professionally in OT, I have an interest in pain, which we're going to talk more about today. But I'm also really interested in advocacy for OTAs and our value in the profession. And I think our value is definitely recognized, but working to advocate for OTAs, but also helping OTAs find their own individual voices in advocacy and leadership is really one of my big passions in the profession. I also have some experience before being an occupational therapy assistant. I have a 4-year degree in communications where I served, or I worked in television news. I started off as a video editor while I was getting my degree, worked as a television news producer. I did go on to do some marketing. I worked for a publishing company doing that, and then a brief stint as a radio personality. And I really,
Wow.
I love all that background because I think it actually makes me a better OT practitioner, just having those experiences.
Yeah, I'm a fan of interacting with any professional really that's kind of got like a depth of knowledge in areas outside of what they do for their quote unquote day job, gives you something a little more to talk about.
Yes, for sure.
Yeah. So Kim, tell us a little bit about you.
So my name's Kimberly Braden, and I am actually an occupational therapist, and I'm one of the founding partners of Aspire OT, which I'm always very excited to tell everyone about. I've been practicing really for over 25 years, and in those 25 years, I've actually practiced as an OTA as well as an OT. So most of my practice is in adult settings such as outpatient, inpatient rehab, acute care, SNF, and home health. But I also had this really great opportunity to work for about 12 years in administration. And I served in a lot of different roles in a couple different settings and companies, but those roles include regional director of operations as well as corporate director of operations. So that really gave me a lot of insight into reimbursement and really improved my understanding how we all work together, in the
Yeah.
healthcare the whole healthcare continuum.
Yeah, kind of the man behind the curtain that clinicians don't often see, but there's a lot of stuff going on, right? Productivity, utilization, all of that. So
And absolutely. And it actually reinforced just what a value that we do provide, not just to the clients that we serve, but to the entire system.
yeah, exactly. It's easy. I come from outpatient OT as well, and it's easy to feel like you're a productivity mule, right? You're just trying to get your numbers, you're trying to hit your minutes for the day, but seeing kind of the value, not just to like you said, not just to the clients that we treat, not to the patients that we serve, but the organization as a whole makes it feel like, okay, we're more than just number crunchers, right?
Absolutely. I mean, we contribute to those outcomes, and I think we contribute more to those outcomes than we give ourselves credit for.
Yeah, absolutely. So tell me a little bit then about Aspire OT before we dive into the main topic at hand here, which is the biopsychosocial model.
Well, Nicole and I are always really excited to talk about Aspire OT. Our continuing education journey actually started with presentations really at the state association level. And one thing kind of led to another, and we began kind of instructing nationally. And we started really becoming disappointed that the professional education companies out there would not allow us the opportunity to provide our courses specifically for occupational therapy practitioners. Rather, we were asked to provide our courses for multiple disciplines. And so this really wasn't as consistent with Nicole nor I's values or our professional missions. So we decided to take those no's and we turned them into yeses, and we created Aspire OT. And so we're a continuing education company that provides continuing education courses that are created specifically by OT practitioners, specifically for OT practitioners. And we also work to support our state occupational therapy associations through our state association partnership program. So we are both really committed to empowering passionate occupational therapy practitioners, and by doing that, through providing very affordable continuing education.
Yeah, and I mean, it looks like you've got all kinds of stuff on your site, everything from spinal cord injury to neurodiversity. It seems like you cover a big breadth of information within Aspire, right?
And that's just the beginning. We're a very new company, so we hope everyone stays tuned to what we can do over this next year.
Yeah, no, that's exciting for sure. And part of the reason that we got connected or we came into contact with each other was I actually attended a course that you did through, I can't remember, one of these big companies, but it was all on the biopsychosocial model, right? Which is kind of what we're here to talk about. So, very briefly, for those clinicians that maybe have heard about it or kind of, you've maybe seen the Lorimer Moseley TED Talks or something like that, but you don't really have a full grasp of what the biopsychosocial model is. Kind of what is it, and then how can rehabilitation practitioners, mainly occupational therapists, kind of begin using it or understand it to implement it in practice?
So, the biopsychosocial approach considers not just the biological, but also the psychological and social factors and their dynamic and complex interaction in understanding health, illness, and healthcare delivery. So, for pain, the biopsychosocial model is the most widely accepted model for the treatment of pain. And it's really recommended specifically by the Pain Management Interagency Task Force. The biopsychosocial model really is very similar to occupational therapy when you think about it. We as OT practitioners believe that engagement in occupation promotes health and well being. And we've always recognized a view of health that's now also adopted by the World Health Organization, that health is really a state of complete physical, mental, and social well being. And it's not merely the absence of disease or infirmity. And so, as occupational therapy practitioners, much like the biopsychosocial model, we believe that you treat the whole experience, right? So, it's
Yes.
the concept of illness versus disease. And I think a lot of the biomedical models focus specifically on that disease process. And we as OT practitioners have always understood that it's about the individual's experience through that condition that really is what is going to improve occupational engagement, that we have to look at the mind body spirit connection. So the biopsychosocial model gives you that framework to look beyond just the biology.
Yeah, it's funny. When I was first, I worked at a outpatient specialty clinic doing mainly chronic pain at the VA. And I was, trying to figure out just in my own professional journey, kind of how I wanted to treat and serve these patients. And I came across the biopsychosocial model, and I was like, wait a minute, this is like everything they taught us to do in school. Only now it's, being applied to a much larger. I mean, at the VA, we ended up rolling out huge biopsychosocial programs that spanned everything, but especially for OT practitioners, like, man, this really feels like home to us, right?
Absolutely. Well, I think that's what we're already trained to do, right? We're
Yeah.
trained to look at all of those aspects as a whole and as equal. They're all equally important. And I think that, we already have that training in developing those occupational profiles. And how we treat. That is our whole lens that we look at everything through.
And I
Yeah.
think I'll chime in here a little bit too. Is the other thing about the biopsychosocial model is that it's client centered. And of course, that is what our training is also all about, and has been for a really long time. And so I really think that that's a really important component too that occupational therapy practitioners bring.
Yes, exactly. Very much patient driven versus, clinician driven treatment programs and goals and all that kind of stuff, right?
Well, I think we've always identified that the patient is the expert in their own life, in their own experience, and in, their own occupational engagement. And so the biopsychosocial model really takes and allows the client to be the expert, kind of building on what Nicole said is client centered, where we are just merely to support them in the process. We're not coming in as the expert to direct, you know, to provide any direction, really. We're just there to provide that support and knowledge.
Yes, exactly. Yeah, we're not doing things to them or for them as opposed to just supporting them through it, right?
Absolutely.
All righty. Well, and you mentioned when you were talking about the biopsychosocial model how it's the most commonly used or most popular framework for treating chronic pain. So let's talk a little bit about just the idea of pain and chronic pain, especially here in the US. Like how big of a problem when we say chronic pain, what kind of what kind of issue are we dealing with here?
Well, the most recent and current information says that over 50 million U.S. adults are thought to have chronic pain. And of those, it is estimated that 19.6 of those are actually experiencing high impact pain, which is pain that interferes with daily life or work activities.
That's
So
19.6 million.
19.6 million,
Holy
yes.
cow. All right.
And so, for occupational therapy practitioners, when we're looking at it interferes with daily life or work activities, we're talking about occupations, right? Whether it's ADLs, IADLs, work, leisure, play, health management, all of those. And so, really, as OT practitioners, when we look at those numbers, we really can expect to encounter individuals with pain in almost every setting that we practice in.
Yeah. Not just your pain clinics, right?
That absolutely. And it's often, not chronic pain, but then looking at acute pain, it's important to look at both acute and chronic. Acute pain is, pain in general is the most common reason that individuals seek healthcare services. And when we're looking at surgical procedures and things like that, pain is, an absolutely anticipated
Yeah, exactly.
byproduct of a procedure. So it's more than chronic pain. We're seeing acute pain as well. And the biopsychosocial model sees pain as biopsychosocial, whether it's acute or chronic.
Yeah. So it's not just a neurophysiological response, right? There's an emotional component to pain and a historical, even context and perception component of pain, right?
Well, social, that's what, those social components, our environment, our culture, those things outside of us that are outside of our control, those things that we as occupational therapy practitioners have always considered as very important in impacting one's health.
Yeah. Well, and you said pain is probably the big, number one reason why patients or clients might come to see us, probably access healthcare in general. How much of that do you think just comes from this idea of like pain being the next vital sign and all of that? Because I think that has led into some of this, like the opioid epidemic that we're seeing, right?
Yeah, and I definitely think, it pain and the opioid epidemic. There's no question is kind of. I mean, they're related. I think how they've impacted and contributed to one another is very complex, and a lot of people who are a lot smarter than I have been working to answer those questions. We know that around 20 years ago there was an increased emphasis, as you mentioned, on treating pain. There was also the increased marketing by pharmaceutical companies regarding opioids and their ability to treat pain. And then at the same time, there was a lack of time for healthcare practitioners and payment systems that really support treating how complex pain is. And really, we know that last one has not changed a whole lot.
Exactly. Yeah.
That's a challenge for us today. But that those factors that I just mentioned really led to an increase in prescribing of opioids. And according to the CDC, that increase peaked around 2012. Also, at the same time, our system, our healthcare system, our culture began to see an increase in adverse events related to prescription opioids. So the CDC reports that in 2017, overdose deaths involving prescription opioids were 5 times higher than those in 1999. And of course, that is all concerning. But the opioid, epidemic, it's complex. And that, even just trying to break down the statistics, when you hear statistics in the media or looking at statistics and research, there's some that are related to only prescription opioids. Other statistics also include illicit opioids, such as heroin. And I'm not necessarily saying either of those statistics are better than the other, but even trying to just wade
Yeah,
through.
but just getting an accurate representation is difficult, right? If everything's kind of being mixed together.
Yeah, so I think it's very complex in how the development of it, and then of course, our healthcare system has systems have been trying to address the combating this opioid crisis, and I think we also have to think about that how the opioid epidemic and the efforts to combat it actually have affected those who have pain. We know in the last several years, especially since the CDC guidelines in 2016, there is data that suggests that there are increase in suicide rates for those who demonstrate characteristics of pain, which is, of course, very, very concerning. Patient abandonment has been a recognized
Yeah.
issue. Um, the U.S. Department of Health and Human Services really acknowledges that stigma is a major concern for those who have pain, and it's a significant, and they use the word significant, barrier to care. And so, kind of thinking about, what the Department of Health and Human Services goes on to say is that we really should be aware as healthcare practitioners that we can't confuse treating pain and treating addiction, that they're two separate things. And I think that's really important to consider in all of this.
Yeah, no, you bring up a whole lot of points there, because there is, when you talk about the opioid epidemic, it gets politicized and there's so much going on, and it's both really a result of policy and incentives, like on an economic level, but then there's also like the whole aspect of what patients expect from their clinicians and how they interact with the healthcare services and the healthcare system in general, right? Is your experience as clinicians treating patients with chronic pain, have you noticed that there's almost an expectation on the part of patients to receive some sort of passive care as opposed to any other kind of care? They want you to do something for them to take away their pain, right?
Well, I think that's not only their expectation, but until I started working with pain, I felt like that was the expectation put on me as a practitioner, right? I
Yeah,
mean,
yeah.
I think before I understood that really the primary goal for individuals with chronic pain is teaching them self-management, I had the expectation that I was supposed to go in, ask that client their subjective pain rating, and somehow through my treatment during that session, I was supposed to lower that
Make it
subjective
go
pain
down,
rating.
right?
Absolutely. So I think I think it's a natural byproduct, right? If we have that expectation on ourselves, then I think those who are receiving healthcare services are going to expect that. And I think that is, one of the big efforts at a national level, through all of the policy changes is to, change healthcare providers' expectations and their understanding of pain, that we're working really towards self-management. And that's definitely a challenge for, the individuals that we're working with, because, for those with chronic pain, think about if it's chronic. So they've been dealing with this a minimum of 3 to 6 months, but
Yeah,
for many, it's been years and years. And so they, have been to multiple healthcare providers, and there's a significant amount of frustration frequently, right? They feel like they're going through a lot of hoops, have experienced a lot of changes in the health or the treatment they did receive, and maybe they were satisfied with that treatment. And so, they're coming to us as healthcare professionals, especially occupational therapy practitioners, maybe not because they initiated that. It may be a product of their treatment was changed, and now occupational therapy
exactly. Yeah.
ordered.
And they're
So
upset.
absolutely. But I also think that that's a welcome challenge for all occupational therapy practitioners, because isn't that how we view all conditions, right? I mean, when you think about our perspective is about enabling our clients to engage in occupation, no matter what their physical, mental, psychological abilities, cognitive abilities are. So I think we are already kind of equipped to deal with that challenge, and we are always, really supporting our clients in becoming better self managers and becoming more active participants in their own treatment. And I think, pain now, as we understand it more, all healthcare providers who are, providing treatment for pain are coming in with that understanding. We need to, improve their active involvement of their own care. But I think as occupational therapy practitioners, that's always been our goal.
Yeah. Well, and it's funny, active involvement and all that. And you see, even in the literature that's coming out these days, everything from, the increase of passive modalities causing, clinician dependence on the parts of patients. And, why would we do this kind of treatment if it's going to result in them wanting to come back next week because they can't get better unless you do whatever manipulation or stretch them or, apply whatever treatment to them as opposed to helping them self-manage, right?
Most definitely. And I think that is that movement from the looking at it from the biomedical lens, from a practitioner and a client standpoint, and looking towards biopsychosocial and looking
Uh-huh.
at illness and the client experience, and then empowering the client to then begin to take active steps to manage that experience.
Yeah. And for those, I'm sure that most people have an understanding of what the biomedical model is, but let's just define that. What is the biomedical model? The one that we've been using for the last couple hundred years and centuries, right?
So, the biomedical model basically kind of sees pain as a biological issue that requires some kind of medical or surgical treatment, right?
Yeah.
And so I think, going outside of pain, the biomedical model sees disease as a process, right? That requires that kind of treatment, and it doesn't take into account the individual's experience. It really focuses merely on those biological factors.
Yeah. It's very much like
And
there's a pathophysiological dysfunction and we have to fix it, right?
absolutely. And when you think about that, are you able to kind of bring that in alongside of managing chronic conditions, right? That approach isn't compatible when you have a chronic condition. So it really kind of makes sense that a biopsychosocial model would be the most appropriate model in, looking at specifically chronic conditions, but just overall. I think as clinicians, we can all attest, we can treat an individual that has the exact same condition, same diagnosis, they receive the same treatment, no matter what it is, but their experience is very different. Their
Exactly. Yeah.
engagement in occupation is very different. And so, what are those factors if they have the same providers and the same treatment? The factors are their individual context, those personal factors that are specific to them, the environment they live in, their culture, their beliefs, all of that are going to impact that.
Yeah. So then let's take a step into kind of how we as clinicians can make a real impact on, maybe it is somebody who's, I had this a lot I was at the VA circa 2013, 2014 when everybody at the Department of Health and Human Services was saying, we got a problem with the opioids, we got to just cut them back. And we saw an influx of patients who came to us and they were, saying, I've been on, fentanyl or this kind of pain medication for years and years and years. And now they're just pulling it cold turkey. So they're in front of you, they're upset because like you said, they were satisfied with the way their pain was being managed. And now that's been pulled away from them. And now they're kind of seeing you and they're like, what now? So how can we as clinicians, as occupational therapists, approach a patient that might be in that situation, understanding that they've been coming, they might have had pain for years and years and years, and they're still not having any meaningful results, if you would. Like, how can we make an impact on their lives?
Well, it
So
starts initially with assessment, right? And so the assessment part is utilizing therapeutic use of self and just allowing the client to really explore and identify their own experience is what I found, addressing the frustration, not arguing,
Yeah.
right? You know, understanding it, validating them as the expert, and really identifying where they're not satisfied and what their expectations are. And then, you know, I think once you establish that with the assessment, then, you know, the foundations for treatment. And Nicole, I'm going to let you take that over.
So I think that, the foundations for treatment, it kind of continues. I think that with the biopsychosocial model supporting, patient-centered care, and we've talked about empowering the client and helping to move them towards self-management. So we have to really develop that therapeutic relationship. And in occupational therapy, we're trained to use therapeutic use of self. And a lot of the literature outside of occupational therapy refers to this as the therapeutic alliance instead of the therapeutic relationship. And so, as Kim mentioned earlier, setting aside our own agendas and thoughts as a practitioner, like those are there, but really being opening to partnering with the client and listening, especially to their narrative, as Kim mentioned, and their lived experience with pain. But I think it even actually starts before that client sits down in front of us. Hopefully, is that as an OT practitioner that we need to seek out additional resources and training for pain. It is widely recognized in healthcare that our entry level training is not satisfactory for pain.
Yeah,
And
across the
so
boards.
Yes, across the boards. And so thinking about if you haven't looked at pain since you were in school or even recently in the last several years, to seek out those. I know I looked at pain, and as Kim mentioned, kind of all wrong when I was working in acute care and skilled nursing before I really sought out some additional training and resources. And so understanding more about the pain process and what influences that process is very important. And that's speaks to that biopsychosocial model. So it helps us as a practitioner adjust our lens to that biopsychosocial approach. But then when that client is in front of us, we want to partner with them to help them understand more about what's happening related to those biological, social, and psychological factors that's impacting their experience with pain and thus impacting their daily life. So if we have a good foundation for that as a practitioner, and we use the time to develop that therapeutic relationship and make sure that they feel heard, then we're able to step in and go, may I talk to you really about some things that you may not be aware of that is influencing your experience, and really starting that partnership. And I think that that's a very kind of practical, approach towards those initial steps during treatment. I also think, thinking about just making an impact on clients who are experiencing chronic pain, it can actually be even a larger scale. So, thinking about a population or a group influence, that really, as OT practitioners, we can work to combat the stigma that clients face. Because if you have worked with someone who has chronic pain, you can hear in their narrative the stigma that they have faced from family and friends, from other healthcare practitioners, from themselves, even, and that is something that really impacts their daily life. So if you're educated on the pain process and the biopsychosocial model, then that allows you to educate other members of the healthcare team and allows you to educate your client about the biopsychosocial model, about the pain processes, and pain can become a disease within itself. And then also talking about the differences between being treated for pain and being treated for addiction. We understand that physical dependence is not addiction, but oftentimes our clients do not. And just speaking up within our own healthcare system, the facility that we work with, our own teams that we work with, to using that biopsychosocial treatment approach for, treating pain that's free from bias, or the assumption that if they have pain and they're on it, that they have an opioid prescription that's being prescribed by a physician, that means that they're going to be addicted and that's a problem. So really addressing the stigma, I think, is big from a population approach.
Yeah, no, I think it's funny, like everything from what you said, this patient might be receiving an opioid legitimately, right, from their physician. Maybe it is in that, whatever the acute window, and they're trying to treat it very quickly and then get them off the opioid, whatever it is. How many patients have you treated that tell you, oh, I'm not going to be addicted, I promise, or, whatever it is. You can tell that they're thinking about it, and they're almost fearful, right, of either becoming addicted or being seen as someone just seeking opioids, right?
Absolutely. And that can impact their recovery, especially for acute conditions,
Uh-huh.
right? In acute conditions, sometimes being able to manage that pain is going to get them moving faster, get them, meeting those outcomes faster. And their hesitance to maybe take those opioids. And we, as occupational therapy practitioners, uh, I think it's out of our scope of practice to, give too
Yeah,
much
exactly.
information on opioids, but we can also, assure them, that they can have a frank conversation with that prescribing provider, and maybe, encourage them to seek out a little bit of additional information before they make that decision, and helping them to understand that, if the prescribing provider felt like it was necessary, there may be some benefits to their recovery.
Yeah. Well, and that kind of hinges back on that therapeutic use of self, right? Like we need to be able to leverage our relationship with the patient to say, no, you can go to this other provider and have a conversation. But I mean, in reality, how many patients come to you and maybe they've seen 5 or 6 other clinicians, and the opportunity to develop a strong therapeutic alliance or therapeutic relationship, whatever you're going to call it, isn't there, right?
So I'm pretty optimistic. I think there's always an opportunity to establish that relationship. And I think Nicole's and I, in experience, both of us would say that we've had a lot of success in doing that. I feel like my training, and my occupational therapy training really prepared me for that. Being able to, utilize not only therapeutic use of self, but motivational interviewing and those coaching strategies.
Hmm.
And also, I think the longer you practice, the more you would think that the more we know, but I think there's more of a recognition of what we don't know the longer
Exactly.
we
Yeah.
practice. And so I think just recognizing that client is the expert and allowing them that opportunity to share their experience and for them to reflect on their experience, because they're so defensive, and I think they're used to being asked a lot of questions, and based on those specific answers. And I think when we step back and let them share, I think that alliance or that relationship just develops naturally. I think if it's less of us and more of them, they can tell. And I think that just listening, like Nicole said, that active listening, people feel like you care if you take the time to listen. And that's really the basis of a relationship, right? Trust
Exactly.
and
Yeah.
and caring. And so if we can convey that we're there for them, not on our own agenda, I think it's going that relationship is going to actually have a better potential for developing, because they did come. I think that's the thing to remember. If they've walked in our door, then they
You're
still
already
feel
over
like
that
there's an
hurdle, right?
opportunity. That's right. They are there. They felt like it was at least worth their time. They may be skeptical, but they haven't given up, right? Because they're there.
Yeah. Well, and looking at some of the literature that's coming out, even what you say about that trust, that being heard, like when patients go back and they rate their satisfaction with services they receive, oftentimes we as clinicians, at least I know I felt this way coming out of a biomedical model originally, like this patient's got to get 100% function back, they've got to have zero pain, and then they're going to rate me as amazing or whatever. But when you look at it, these patients are rating things like, I was heard by my clinician, they understood me, right? They took the time to listen to me, all of those things that aren't really like technical, right? It's kind of the soft skills or the interpersonal skills that play such a huge role in developing that trust and relationship and ultimately making patients more engaged, right?
And I think sometimes it's about being a little bit vulnerable as a clinician. A lot of times, for me, when I was working with someone who had chronic pain, and we were kind of discussing, different strategies or pain science neuroeducation, pain's neuroscience education, that I would just openly say, because for myself, I don't have chronic pain. That's not something that I face in my life every day, and so I would acknowledge that and say, in this room you are the expert of living with chronic pain every day. And so I would love to hear your opinion. I want to hear about your experience so that way we can work together. And so a lot of times I just even acknowledged it out loud because I think that that is so important towards being genuine and building that trust.
Yeah.
And
That whole idea. Yep. Up, keep
a
going.
strengths-based approach,
Uh-huh.
and finding, like as Nicole said, when they share their experience, you're going to find what they've succeeded at. And when you can help them identify what they've already been successful with, they're going to actually feel, more confident in being able to go to the next step, right? Because if you can identify what they've done well, instead of, I think, a biomedical model, we always look at what's impaired, right?
Yes.
We're always pointing out what is not within normal limits, what hasn't met the criteria, right? With our standard deviations and our standardized tests. And so I think when we can look at it from a strengths-based approach and help them identify they've already been successful, right? If they are, if they've been able to manage with their pain for 3 months, they have successfully been able to deal with their pain in some level for 3 months. So what is it that you feel like enabled you to do that, and how can we build on that?
Yeah. Well, and part of this, I'm assuming too, involves understanding like a client's, like we said, they might come to you and they might be skeptical, right? So sometimes we've got to get them over the hurdle, even like taking if you're going to go through like a behavioral change model or something like that, but understanding like this patient might be pre-contemplative, like he might not even know that or even see the value that we might provide or what there's the reason for being there even, right? So we've got to take him or her and get them from this idea of kind of being on the fence about becoming engaged in treatment to kind of taking action, right? And how much of that do we need to be involved with as clinicians, and how much of that is kind of we do our best and we hope that they get there, right?
So I think that that's the beauty of occupational therapy is that we're kind of trained to go through that process to support the client so they can find their own reasoning, right? So the use of motivational interviewing so that it's the client's own self-discovery through the facilitation of the questioning by the OT practitioner. And I think that's one area that we can really shine is that we don't want to take someone and just if they're not following through with recommendations. So the easy one to think about is like a home exercise
Exactly. Yeah.
program, right? Which we love being occupation based, but we'll use the easy example. But so thinking about, well, sometimes those folks get labeled non-compliant. But what if, we need to think about where they are in that stage of change, and then how can we use the tools that we have as OT practitioners to help the client see their own reasoning and their own goals to then institute that change.
Yeah. Well, we've talked about motivational interviewing a couple times here. So for those clinicians that might be either just starting out or don't really have a real understanding of what motivational interviewing is, kind of let's just define it. What is motivational interviewing, and kind of what's an example of a question that would qualify as a motivational interviewing question?
So, motivational interviewing is kind of a client-centered interview approach, and it's really based on trying to help someone identify how their behaviors are lining up with their actual desires, right? What we want to do and what we're actually doing. So, I think questions just asking about, how satisfied someone is. I think I've encountered this several times where have individuals with chronic pain, but they're very satisfied with their occupational engagement. Right.
Yeah.
And so we just assume because they have pain that they're going to need to participate in some program but if they're satisfied and they're doing everything they want to do and they still have pain, I think sometimes that's the first thing to identify. Is there a gap in what we want to do and what we're actually doing? So, from a motivational interviewing question, and Nicole may have a better example, but just kind of asking someone, you mentioned that the doctor, felt like it was really important to increase your physical activity for your overall pain management. And you mentioned that you're not doing that. So can you tell me a little bit about why you're not doing that? And, what is the doctor said, he felt like your pain probably would not be able to, was not going to improve if you didn't try to improve your self-management and increase your physical activity. So tell me why you're not concerned about that, right? Instead of saying, why aren't you doing it? Tell me why you're not concerned about your pain, not improving or getting worse. Nicole, you might have a much better example than I came up with.
No, I think that was a good one. And sometimes even just starting off and saying, so what are you concerned? What's your level of concern? And a motivational tool, interviewing tool that can be very useful is because really at this point, you're asking for some pretty subjective information. So, give them a scale, on a scale of 0 to 10. How concerned are you about this? Or how likely do you think that you would be to change? And so that gives you a way to kind of measure a little bit. And then through some discussion, you can follow up later on. You can ask permission. That's very important in motivational interviewing. If you are going to provide education, ask for permission. Would it be okay if I shared some things? And then at the end, you can follow up and ask that scale again and see how that changes for the client. And that gives you some really great information, and you can kind of start to see if that they might be moving along to planning or an action stage.
Yeah. Or they might just stay, be the same, right? In which case you either go back to the drawing board or you come up with another strategy, right? Right.
And sometimes that's when you really try to start to listen. This is where the therapeutic alliance comes in, is listening to what is important to the client.
Yes.
So if that motivational interviewing, you're not really kind of getting anywhere, maybe you should shift gears and maybe they've talked about, if they mention the grandkids and their face lights up and how much they really just want to enjoy being with their family. So then you can start to say, so how much does this influence, it sounds like your family is really important and cooking meals for your family is really important. How much do you feel like that your pain is impacting that? And then that opens the door to them saying, possibly, yes, this really impacts it. And so have you ever thought about, do you have ideas about how then you could work to have that impact be less? And you have to listen. That's the thing about motivational interviewing. You can't ask the question with an agenda for the answer you want. You have to really turn on that curiosity, which I think is one reason why I really love motivational interviewing, is that you have to be truly curious about what this client's ideas and needs and desires, the motivations are, so you can help guide them to those things.
Yeah, you're not asking a question with an answer in mind. You're really it's totally unjudgmental. You're just trying to listen to get down to the root. Like, what is really motivating this particular client in this particular situation, right?
Yes.
And really, I have come across very few individuals who have goals. There's something they want to achieve or they're dissatisfied that weren't willing to consider their options. I think it's about, we have to identify first if there's a gap. Is there something they're not doing? Because a lot of times we want them to do it or the physician wants them to do it. But if
Yes.
that's not a goal for them personally, whether it be weight loss or, anything else, then I think we have to understand that that's not their personal goal. But I have come across very few people that really had goals and they weren't doing what they wanted to do, they were dissatisfied, that they weren't willing to consider their options. But a lot of times I think we have to understand the history. How many times have they maybe tried that in the past and it wasn't
Yeah,
successful?
exactly.
We really have to kind of learn, why do they have these beliefs, right? Their beliefs may not be based on fact, just maybe their experience. They may believe because they've tried it twice that it's not going to work. And we might have to, educate them to, well, maybe there are some other ways to, implement that same strategy. Maybe these were things you hadn't tried.
And
Yeah.
also sometimes asking that question of, so, for example, if somebody's been recommended to, lose weight, at doctor, healthcare practitioner after healthcare practitioner, or foot checks is another one, really just taking the time and going, so I know you've heard about, I'm assuming somebody's, talked to you about this before, and they'll go, oh yeah, and, potentially, and then go, so did anybody ever tell you why? Like, is that curious? Are you curious about that? And they'll go, no, I have no idea why they want me to do this. And so there's a missing piece in all of this. And so you have to take that time to ask and use the relationship to find out information, and then through permission, motivational interviewing sometimes to find the motivation for maybe why they want to do that. But it also helps if they understand like the rationale too.
Yeah, just sometimes baseline knowledge, right? I tell students and clients and all that when I do trainings and stuff. It's like, oftentimes the physician is in there for what, 7-10 minutes with a client, usually with the patient, before they refer them to somebody else. And part of what ancillary healthcare services, OT being one of those, has a real advantage in that we see these people for what, an hour at a time, maybe sometimes multiple times a week. Like the ability to drill down and maybe it is discover that piece of missing information or drill down to the real motivation is really one of the skills and one of the gifts that we have in our model of service delivery, right?
And maybe it's not motivation. Maybe the motivation is there. Maybe the environment isn't conducive.
Yeah.
If we have someone who has a diabetic diet and they're labeled non-compliant with that diabetic diet, is it because they maybe don't have the financial resources to afford better food choices? I'm in a rural area in East Tennessee. Nicole is too. Some may not have an operating stove. Right. I mean,
Oh, wow.
we
Yeah.
really have to kind of think about things like that. Is the environment supporting that? Sometimes it's things totally out of their control. A busy mom who's working 2 jobs may have a really hard time implementing new routines. Right. So it's about, I think that's, the beauty of occupational therapy is we can look at all of that. We can break all of that down, assess all of that, and see if we can find what the barriers are. It may be well beyond motivation. It may be beyond, it may be a situation where the resources are just not in place.
Yeah. Almost as social determinants of health, right? It seems like that's been
Absolutely.
getting more and more popular and for good reason.
Absolutely.
So then kind of pulling it back to the biopsychosocial model and implementing it into practice, what would you see as maybe the major challenges or barriers to clinicians and organizations implementing a biopsychosocial approach to both assessment and treatment?
So, from assessment, I feel like from an occupational therapy perspective, there's very little barriers,
Yeah.
right? For us, I think it's really important. One of the things that I realized very quickly when I started working specifically in pain was that as an OT practitioner, I lacked an understanding of pain. But I had all the skills to treat and assess it from a biopsychosocial model. I didn't need to learn those skills. And, the pain management best practices interagency task force identifies that across all healthcare fields that there's a lack of training to the treatment of pain. And what I would distinguish is occupational therapy, we lack the training to the understanding of pain as a biopsychosocial
Hmm.
condition, but we have the training to assess and treat it. So I think we face fewer challenges in the assessment part. Think one of the challenges I see is I think there's a doubt or a concern of implementing these that kind of approach, whether it's medically necessary, right? Looking at it from
Yeah.
a reimbursement model. And so I think that's a huge challenge. And I think that if we start really looking, more and more research is coming out, not just in pain. I mean, the evidence is there. That is the approach to use for pain. So all of our interventions are medically necessary, right? If they're biopsychosocial interventions. But I think there's a lot of evidence coming out from, the perspective of chronic conditions in general, that this is a good model to use. So I think the biggest challenge is understanding, specifically as OT practitioners, that we don't need to just focus on the biological to support medical necessity, that, it is identified that it's the mind, body, spirit, that all of those biopsychosocial components do qualify for medical necessity, and, that we need to implement all of them to improve health.
Yeah. And hopefully as time goes on, we move into like value-based reimbursement models or something like that, where we don't have to worry too much about that kind of thing.
And then from a treatment perspective, what do you think, Nicole?
So from a treatment perspective, I think kind of one of the biggest challenges is maybe our own habits and routines as OT practitioners. Um, as treating clinicians, it's very complex right now. The productivity, payment models, all of the challenges related to COVID. There are so many demands on OT practitioners when we just want to walk in and provide the best care that we have. So thinking about, because we haven't necessarily, because we know that across healthcare, the training has not been there for entry level. And so thinking about on our radar might not be, we look for pain, like we've been taught to, as Kim mentioned, assess and ask. But maybe we need to make sure, especially if it's not the primary diagnosis, so when we see chronic pain or when we understand that there is pain, to just have this little light bulb that goes, it's like a little whisper, biopsychosocial. Make sure related to pain that I take time in my habits and routines related to my clients that I'm thinking about that. And trying to work that into where that's part of what we do with every client, because it may not say that on their chart. They may not say that they have chronic pain. Hopefully it does, but, or, maybe they are having some sort of acute condition that their pain seems very unmanageable, so that then we shift to consider that model and maybe not the traditional lens that we're used to doing to try to get through the day.
Yeah. So as far as overcoming those challenges, you're basically saying we just need to begin changing the way we're doing the way we're doing things, right? Like we need to begin making almost an active and concerted effort to begin implementing a biopsychosocial, at least keeping it in the back of our minds when we're seeing a patient, regardless of what's going on, right?
And I think, that seems, for OT practitioners, I don't think it's a huge shift, because I think we already practice, as we've talked a lot about today, in that biopsychosocial model, but making sure that, identifying some small changes that we can make, it's maybe a Post-it note, to kind of call our attention to it, because we know we have to get outside of our routines and habits if we're not specifically thinking about that related to pain, because maybe the training previously hasn't supported that. So I don't think, I think that, I think definitely from a systems standpoint in our healthcare, biopsychosocial would definitely benefit a lot. And I think OT is already there, but maybe for pain, for practitioners that haven't had additional training, that's just some small changes that you can make that aren't overwhelming, that really can have a big impact for your clients that you're treating who have pain.
And I think one thing we haven't talked about, but I think that the biopsychosocial model actually provides this wonderful opportunity is that I think for a long time, we as occupational therapy practitioners have kind of had our own language,
Mm-hmm.
and the frames and references that are frameworks that we use in our models, I don't think that they've been very well understood by other healthcare professionals, specifically, providers, medical providers. And I think that the biopsychosocial model has really allowed us to start speaking this common language, because the biopsychosocial model is much more broad than what we as OT practitioners, um, our frames of reference and the way we look at things, we break it down into even more factors. But I
Yeah.
think it's a really great starting point, right? That we start speaking a common language, because when we can communicate effectively and when we can refer to things in terms of the biopsychosocial model, more and more practitioners are becoming, medical practitioners and medical providers are becoming familiar with this. Now we can start really promoting our value and really articulating, I think, easier what it is that we do, that it's beyond fine motor coordination.
Yeah,
It's
exactly.
beyond dressing and bathing, right? That's how occupational therapists have, or occupational therapy practitioners have always practiced. And so I think there's this huge opportunity for us, if we can start weaving that language into, our discussions and how we promote our profession.
Yeah, I teach a student course here in Augusta about it's adult intervention and assessment and intervention, and we talk about interprofessional communication and practice. And one of the big exercises I do with them is try to have the students come up with, quote unquote non-OT language for when they're communicating with a doctor or communicating with, even a physical therapist. A lot of doctors don't understand what occupational deprivation is, right? But there's ways that we can use common language to get everybody kind of on the same page.
Absolutely. And I think this is a great opportunity for our profession specifically. And I don't think that we have always recognized that. I think that as Nicole and I practice in pain, the more we practice, the more we realize there was a really big gap in how
Absolutely.
the psychologist and the psychiatrist and the medical providers and the nurse practitioners, the language that they use, the vocabulary, their perspectives on pain, and how different they were than all of the rehab professionals. It was like we were
Yeah.
almost speaking two different languages sometimes. And we credit a lot of our success into the fact that we understood, we took the time to really go to learning events and things like that that were specific to those providers, so we could understand what their perspectives were. And then we were able to communicate much more effectively. And the biopsychosocial model allows us to do that across the board, not just in pain.
Yeah. No, that's great. Well, we're getting near the top of the hour here. Thank you all very, very much for taking the time. I'm just going to pitch a question to both of you here. If you could just give somebody kind of like a final thought, big takeaways, what would they be? We'll start with you, Kim, and then we'll move to Nicole.
As far as the biopsychosocial model for pain, or the big takeaway from what specifically?
The biopsychosocial model for pain. Yeah.
I would just encourage occupational therapy practitioners to really have confidence in their skills and their training in treating pain. And I would encourage them to seek a more in-depth understanding of pain as, from that biopsychosocial perspective, but just really encourage and hopefully empower OT practitioners that you have this training, and this is a field that you are well equipped to provide services in.
All
And I
righty.
think, and I think for me, for OT practitioners to really take a step back, and as much as you're able to, use all of your active listening skills and empathy to really stop to think about that the clients who have especially chronic pain, what their lived experience is, how almost all of their daily occupations are impacted by this, and really use all of that to then develop that therapeutic alliance to really begin to implement the biopsychosocial model, because I think that's when beautiful things happen, when we support our clients in their own goals, and support our clients through navigating the challenges that are getting in the way of the goals that they have.
Awesome. Well, great. Thank you all very much. If people want to find out more about you, about your work, about Aspire OT, where would they go?
So our website is www.aspireot.us, and we do offer live courses related to treating pain as well as webinars. And soon we plan to have an on-demand class that folks can take at any point at their own pace as well.
Awesome. Well, thank you all very much for taking the time, guys.
We
Thank
appreciate
you for having us.
Appreciate you asking us.
Well, I hope you enjoyed that conversation with Nicole and Kimberly from Aspire OT, talking about how clinicians can actually treat and serve and communicate with patients in chronic pain. It is not a secret that the biopsychosocial model is something that is foundational here to the work at the Better Outcomes Show and to the consulting work that I've been able to do for the last few years through Rehab U Practice Solutions. I think if I could only add my own personal takeaway after listening to it again is, again, the importance of communication and how we communicate with patients, not only to manage their expectations, not only to provide educations, but to truly empower them to be drivers in their own healthcare. And we talked a little bit with Nicole and Kim about motivational interviewing and how you structure questions and what types of questions you ask and how that can affect the perception of your clients and the way they think about what is going on in their situation. It makes them, if you ask a question a certain way, you can have the patient almost step back and be a little bit more reflective, if you would, about their situation and why they're making a decision or why they think they need a certain treatment over another. Again, I don't think I can overstate the importance of being able to effectively communicate and how big of a skill and crucial of a skill that truly is in healthcare. I'm always saying the hard skills are the soft skills, or the soft skills are the hard skills. Like, it's very easy to get all the technical knowledge down, but what we really need to be focusing on is how we communicate, how we build relationships with patients, all of that. So those are my thoughts on that. Anyways, if you like the show, head on over to iTunes, give us a rating and review, subscribe if you want to. You can go to www.betteroutcomes.show, sign up for our email list, and we will send you the new episodes as we drop them. We drop interviews every other week, and then every now and then you'll get a bonus episode, a solo episode, or sometimes a bonus episode that is an interview. So until the next episode, guys, be safe, be healthy. I'll talk to you then.
Thanks for listening to the Better Outcomes Show, where we explore the possibilities of a new healthcare. Our hope is that you walk away from each episode informed, equipped, and empowered to push the boundaries in your own practice or business. We want to give you the tools to help you build strong, long-lasting relationships with your patients and clients, helping meet their goals, improve their health, and achieve better outcomes. Learn more at www.rehabUpracticeSolutions.com. We'll catch you on the next episode.